All right, we're good? Okay. They can hear me, right? If you guys can't hear me, just go ahead and like drop a comment in there and I can always move this microphone. My name is Dr. Jordan Watts. You guys previously saw me working over at Freeman and now I'm working over at Mercy Joplin. So it's good to still be in the community and I'm grateful to be back here with you guys again. My lecture this year is going to be on brain and spinal cord trauma. And we will get right into it. So a couple of things that we'll cover. We'll just cover some very basic like anatomy and physiology of the spinal cord and brain, which is definitely important when we think about the mechanism of some of these injuries. We'll talk about different types of injuries of both the brain and the spinal cord. And like I said, mechanism of injuries, we can kind of predict what some of the injuries will look like and how they'll present, how we can manage these injuries in the field. Some special considerations, and ATLS updated this year. That's kind of the advanced trauma life support that all your hospitals are undergoing training for, especially in the ER. And so just some kind of like cool things that they came up with this year for the providers for you guys to think about maybe. So we'll start with a case. You'll have a there I was moment. You're at the pool with your kids and you witness this middle-aged guy dive headfirst into the pool, requires a lifeguard rescue, doesn't come up after a few seconds. He's awake when they pull him up, but he says, I can't move my arms and my legs. When you're just trying to enjoy the day with your kids, but there we are. So what's the first thing you do on scene as, the first EMS bystander, right? Oh, too many. Okay. ABCs are always coming first, right? No matter what we're concerned about the injury, it's always going to be ABCs. We're making sure airway's intact. We're making sure patient has bilateral breath sounds the best we can in that setting. And then circulation's good with good peripheral pulses. Somebody comes running over with an AED and a little machine. You can check some vitals. They look okay. But as you're maybe calling for somebody to come transport the patient, what are some things that you can think of to suggest for this patient in transport? Or if you're the one responding to the call, what are some things that you can do before or during patient transport? Pain control, obviously, cervical spine immobilization, right? Somebody who can't move their arms and their legs, but was previously just jumping into the pool. We're worried about a cervical spine injury. I know you guys probably still carry spine boards. Maybe expose the patient, make sure there's no other underlying injuries that would be worth reporting. You can always do a brief neuro exam, like, can you feel me touching you here? Can you squeeze my hand? Can you lift this leg? That kind of stuff. Some of that information is definitely helpful in pre-hospital reports, right? When we talk about spinal cord anatomy, we're talking about 31 pairs of spinal nerves that are kind of protected by the vertebral bodies. It begins at the base of the foramen magnum, which is like if you look at a skull, there's a giant hole at the base of it, and that's where the spinal cord starts and comes out and down the back. It's divided into four main segments. You have your cervical spine, your thoracic spine, your lumbar spine, and your sacral spine, and we'll go into each of these just a smidge. As far as cervical spine anatomy, you've got 7 cervical vertebrae and 8 cervical nerves. So your 8th cervical nerve is going to come out underneath C7. There's 2 atypical vertebrae. The ones we kind of worry about the most is C1, the atlas, which connects to the base of the skull. And then C2 is your axis, which is kind of a very fragile vertebral body. This is the most likely part of the spine to be injured just based on the way that it's built, right? So your lumbar spine and your thoracic spine are bigger bodies. They're protected by your rib cage and basically the trunk of your body and your pelvis. But the cervical spine is really just held together by soft tissue, if you think about it. And so it's definitely susceptible to a lot of injuries. You just don't have that stability there. And so that's why we take that really seriously, because obviously most of the main nerves in your body are starting there. And by severing your spinal cord there, you could get into a lot of trouble. Then you have your thoracic spine, which comes right beneath your cervical spine. You've got 12 vertebral bodies in the thoracic spine that protect 12 spinal nerves. There's no atypical vertebrae here. The bodies get a little bit bigger and more sturdy. They're attached by the rib cage, so you get some additional support. And you're housing essential organs in there. So while this part of the spine is important, it's very well locked into this part of the body. So injuries here are actually not super, super common. Just remembering at T3, you're looking at kind of the base of the shoulder, like the shoulder blades, that part that kind of sticks out on your scapula. And then as you come down to the bottom of the shoulder blade, you're looking at T7. So just some landmarks that you can remember when you're evaluating a patient, kind of feeling on them to see where their injury might be. Those are just some helpful landmarks to kind of remember. Then you have your lumbar and your sacral spine. So You have 5 lumbar vertebral bodies. These are the largest and the most sturdy of the vertebral bodies. They support the most weight in the body as well. While they're not connected by anything more than the pelvis, it tends to be really well supported. The spinal cord terminates at L1 to L2 in adults and L3 in kids, just kind of a fun fact. And then the cauda equina is what forms beyond this. So we describe it as kind of like a horse's tail, and it just kind of splays out underneath the spinal cord. And then there's 5 fused sacral vertebrae that follow that. The sacrum obviously connecting to the pelvis and keeping the bottom half of your back really stable. Okay, so what are some of the functions when we talk about the spinal cord? All kinds of like really, really detailed, intricate stuff. But motor and sensory function is kind of the main one that we think about. So we think about our guy diving in the pool, can't move my arms, can't feel my legs kind of stuff. That's one of the main functions of the spinal cord. For sensory, we think of these dermatomes. Now, this is like a really fancy thing, but when you see some of the providers doing like, hey, can you feel me here? Can you feel me here? Can you feel me here? It's kind of like we're trying to figure out where the injury is. But it's just kind of a cool way to see where those nerves are innervating, like our skin and our sensation. And then you have pain, touch, temperature, proprioception, all of that stuff. Really, really detailed, intricate process when you think about it. The spinal cord does do some autoregulation of internal organs, especially up by the brain and spinal cord up at the top. Breathing, heart rate, digestion, sweating, all kinds of functions are controlled by the nervous system in general. Reflex coordination, so that whole like, hey, I touched a hot stove, and as soon as I felt that, it didn't take my body a couple seconds to realize, hey, my hand's on the hot stove, right? I can pull back almost immediately because those messages sent through the nerves in the spinal cord are so fast. So that's something really helpful. We want those reflexes to be intact. And then this one that's kind of interesting that people don't really think of is injury recovery. Studies have actually shown that a healthy spine is really crucial to all kinds of injury recovery and the way that we perceive pain, the way that we regain motion. And so a healthy back is actually really important, a healthy spinal cord. So when we talk about, like all these new studies showing that we can help dementia patients or help like patients who are like paraplegic from an injury, having a healthy spinal cord is really important. So not something that's like super intuitive, but something that can be really helpful. Okay, so mechanisms of injury when it comes to the spinal cord, you can have primary and secondary injuries. Your primary injuries are going to directly impact the spinal cord. It causes immediate impairment. So we're talking like things like whiplash injuries that completely transect that part of the spinal cord. We're talking about blast injuries or gunshot wounds to the spinal cord that immediately cause, let's say, weakness or paralysis in the legs, stuff like that. And then you have secondary trauma or secondary injuries. These are things that will cause, let's say, hyper exaggerated movements or something secondary to the spinal cord that leads to injuries down the road. So things that cut off blood flow or oxygen supply to the spinal cord. Kind of a little bit beyond what you guys do in the field, but it's interesting when you think about it. So like it might not have been a direct injury to the spinal cord, but there could be reasons why this patient over time is getting worse and worse and worse. And you guys make those calls where like, oh, things have been going on for a week, and it could be related to something like this. Maybe? Oh, there we go. Okay, so you were driving around town and you were looking at some guys fixing a roof, and then you see this guy fall, or a bystander tells you that he just fell and landed straight on his head off of a single story roof. When we talk about the type of injury that this would be, does anybody have any ideas? Okay, we're talking about a compression or an axial loading injury. So there's a high amount of force that pushes down upon those vertebrae from the head. You can also get this the other way, right? If you land on your feet really hard, you just kind of get it from the other end of the spine. But it's this high amount of force that pushes down on the vertebrae and causes compression and fractures of the spine. It can lead to disc herniation, nerve impingement, fractures, obviously. But these can be really dangerous injuries, especially when somebody's laying on their head. Sometimes we see a lot of these complaints in kids, like, oh, they fell off the playground and things like that. So obviously a worrisome injury depending on how high you fall from. All right, next one, you got a call on a patient that was rear-ended. They were at a stop sign and the car behind them was not looking, went to bend down and pick up their cell phone and smash the back of their car like 50 miles an hour. They then hit the car in front of them, and it's this whole like long train wreck of cars crashing into each other. The patient in the first car that got hit is complaining of severe neck pain. So we think of a mechanism like this, we're thinking of hyperextension and hyperflexion, or these are your whiplash injuries, right? So their initial injury is that head going forward and hitting the steering wheel maybe. Then as they hit the other car, it shoves the car back in the other direction, and then they hyperextend in a posterior direction. This can rupture tendons, ligaments, and like we said, that cervical spine is really susceptible to injuries, so it can lead to some pretty significant instability. It's going to stretch out that spinal cord. It leads to inflammation and swelling, and even though there may not be a direct primary injury, these are the kind of things that you can worry about, those secondary injuries. So like these are people that might live with chronic neck pain due to some of that inflammation and swelling that sometimes we can't always fix, unfortunately. Okay, the next mechanism we'll talk about is a patient that attempted to hang themselves, but the rope broke and the patient was found kind of laying on the floor. This is a distraction injury. So we say a body in motion isn't always in motion, but sometimes a body in motion can suddenly stop. This is the same kind of idea where it stretches out that spinal cord and causes damage within the ligaments and the tendons of the spine. And again, we talked about the cervical spine being most susceptible, that even if they fell from a significant height, I'm still more worried about the cervical spine than anything else. Something that we think about frequently and like is heavily taught in emergency medicine is a hangman's fracture in this instance. So basically, it breaks the part of the spine that basically connects um, the um, the vertebral body to the rest of the spine, and you can fracture that pars interarticularis. That's kind of a little bit of a nuance, but that's a very dangerous part of the spine to break, and it's specifically called a hangman's fracture for that reason. It's a very unstable cervical spine fracture. These are people that need cervical collars for a long time. All right, the next mechanism we'll talk about is a female boxer. You're a ringside paramedic, you're a ringside doctor. You see her kind of get hit on one side of the face, and when she falls, her neck lands on that. I know it's not like a rope, but it's that bouncy thing that kind of keeps them in the ring. She lands on the side of her neck. She's no longer able to move half of her body, and she's having some trouble breathing. You can have these lateral bending injuries. So they're kind of similar to flexion extension, just literally side to side. But half the body can be affected by these kinds of injuries, which is interesting. So she might have been like, oh, I can't move my right arm or my right leg versus like my whole body, I can't move. But same kind of idea. You can still rupture tendons and ligaments in the spine, leading to inflammation, swelling. Same type of idea with those kinds of injuries too. Okay, and then we talk about types of spinal cord injuries. These are most of them are some of your secondary injuries. Some of them will be more primary, but a lot of these are going to lead to failure to get oxygen and blood flow to the spinal cord, which obviously we still need. And so these can be very dangerous in that regard. When we talk about cord concussion, you can concuss your spinal cord the same way that you can concuss your brain. It's a temporary loss of function that eventually resolves on its own. It could be caused by blunt trauma. It could be due to like a secondary type of injury, but these can be really uncomfortable and really painful and can cause neurodeficits. Cord contusion is exactly what it sounds like. You get some kind of swelling or bruising of the spinal cord leading to neurologic dysfunction, and it resolves as the cord continues to heal. So those two things are kind of very similar. And then cord compression. Some of you guys probably have some back injuries and you've got some cord compression within your back as they swell and lead to ischemia. And sometimes these things are permanent. Sometimes they can't be fixed neurosurgically. But if you guys have chronic back pain, could be why. And then you have lacerations of the spinal cord, right? Like these are quite literally bone fragments, puncture wounds, gunshot wounds that can lead to swelling and compression of the nerve bundles. Two of the big ones that we'll talk about though are like complete and incomplete cord transections. These are definitely important, especially when you're the first one on scene, trying to figure out what happened, trying to figure out what to do with your patient, right? This is when the cord becomes entirely separated from the segment above it. And this can be, that guy that jumped in the pool. This can be that high speed MVA. It can be from a lot of different things, but the level determines the presenting symptoms and what our patients look like, right? So below T1, we can talk about patients becoming paraplegic, and above T1, we talk about patients becoming quadriplegic if this injury is significant enough. You guys probably know this little saying, but like at C3, C5, we want to keep the diaphragm alive. So injuries that are higher up in the cervical spine, we worry about respiratory compromise. So now we're looking at a whole different thing when you guys are on scene and you have a patient that's got some kind of cervical spine injury or spinal cord injury and isn't breathing, right? And we'll get into some of kind of the meds that you guys carry that are recommended for neurologic injury versus not. And then you have your incomplete cord transections. These are kind of like a little bit more advanced, and but there's different syndromes when you have an incomplete cord transection, depending on the level of the spinal cord and the anatomical nature of the spinal cord that it affects. So we won't go too much into this, but central cord is one that you guys might see a bit caused by a hyperextension injury. So maybe like somebody gets hit from the front of a vehicle and their neck goes back too far. This is when they lose sensation and motor function in the upper extremities. And again, it could be, it's usually an upper cervical spine, upper thoracic spine type of injury. But there's all kinds of different cool syndromes. It's like, okay, if they lose like sensation and motor on one side and then proprioception and pain loss on the other side, kind of like some really advanced things, but I do find them quite interesting. Okay, we're working on some dad jokes in our house because we're pregnant. So, what's a horse's favorite song? Because we're gonna. My husband did not appreciate the song. Purple Rain, get it? Like nobody gets it. Okay. He didn't think it was very funny, but I was like, we're looking for new dad jokes in our repertoire here. So, because I'm leading into the cauda equina, right? So you're called for back pain. You went to a rodeo site, and a young male was bucked off his horse, landed straight on his bottom. Then over time, he developed really severe low back pain. He says he's weak in his legs, he's numb in his groin, and he's urinated on himself. This is something we're talking about, cauda equina syndrome. This is a neurosurgical emergency. This, when people tell me they actually can't pee, urinary retention is going to be the most sensitive finding for one of these types of injuries. When they tell me they can't pee, I get a little more nervous. So all those people that are peeing on your cots, you just remember that, okay? Compression of the peripheral nerves at the bottom of the spinal cord. Like I said, it looks like that horse's tail really nicely after the spinal cord ends, but it's basically compression of those nerves due to an injury. And we talk about red flag signs for back pain. Uh, Low back pain, obviously concerning, obviously painful, but when they start complaining about numbness in their groin, and the way that I ask this question is like, when you wipe to go to the bathroom, can you feel it? Because it's really that feeling along the perineum that I'm talking about. The upper groin is innervated by different nerves, but when you wipe to go to the bathroom, can you feel that area? And then retention and incontinence of bowel or bladder. Like I said, urinary retention is actually the most sensitive and most specific for this kind of injury. So just remember that. And then leg weakness, whether it's bilateral or unilateral. Okay, so how do we treat these people, right? We talk about getting on scene for all of these concerning injuries, but what do you guys carry that you can do for the patient? Obviously, you want to determine the type of injury. I'm not always putting somebody in a cervical spine for a low back injury. Depending on the mechanism, it's probably a good idea, just presumptively. But you've got your cervical collars, which provide cervical immobilization. You've got soft and rigid collars, but it's typically an initial trauma evaluation. We're using those rigid collars, you know. And then you have your short spine boards. I don't know if you guys carry those, the short spine boards. No? Okay. Well, those are a thing, and they can be used intermediately until a long board can be obtained. But this is going to support more of the upper back, the cervical and thoracic spine. I can imagine that thing and kind of ending right in the middle of your back, especially if you're tall, can be super uncomfortable. So a lot of times we just say just use the long board, and they're not even 100% recommended anymore. But if you've got a long board, don't be afraid to throw them on there for a short transport because it can help immobilize the spine completely. But like I said, we got beef with spine boards, right? So the biggest things, why do we worry about these? Pressure wounds, respiratory compromise, and pain. So you want to be very cautious when using these spine boards. Patients have developed pressure wounds up to 30.6% of patients, okay? And they can develop as early as 30 minutes. So when you're talking about long transports, like when you guys are driving our patients up to Kansas City and out to St. Louis, and they're on a spine board, you have to be extremely aware of this, okay? And we don't really do that anymore. But you know, you never know. You're gonna get a weird case, and you're gonna be like, they got to be transported on a spine board. So some things to think about: the straps over the chest can cause a decrease in pulmonary parameters. So your elderly patients, your patients with not a lot of reserve, like young kids, people with like COPD or respiratory dysfunction of any kind at baseline, you want to be careful that those straps are not too tight, so they're able to take big deep breaths, right? And again, like I said, in pediatrics, they found a reduced vital capacity of up to 80%. So this is something you definitely want to look out for. But they can also be really painful. So you kind of want to pad the boards as best you can if you do have a long transport with these patients. If you guys don't carry them, I'm sure the hospitals have them, but towels, blankets, make that board a little bit more comfortable in all the nooks and crannies. In 2013, they actually came out, the American College of Surgeons, that they don't really recommend the routine use of this. And when I say that is like patients that have a GCS of 15, so they've got a normal level of consciousness. There's no spinal column tenderness or abnormality. That comes with your brief neuro exam that you're doing on scene. And then no distracting injuries and no intoxication. So if they're intoxicated, you just have to pretend that you don't believe anything that they say, no matter how much alcohol they said they've had to drink. Just be safe rather than sorry, especially for a short transport. Throw them on the board, get them over to the ER, you know. But those are some of the same criteria actually for using cervical spine collars too. So just keep that in mind when you guys are using the spine boards. I feel like we see air teams come in with them more often than not, but you know, just some things to think about when you've got people on spine boards. Okay, let's move into some more brain stuff. So you're called to scene regarding just a bicycle wreck. There was a middle-aged male going to work, got hit in the crosswalk, patient landed on his head. was not wearing a helmet, had positive LOC, and the patient looks kind of confused now. You see this large frontal hematoma, laceration, skull exposure. So now we're talking about more brain injuries, right? When you talk about the anatomy in the brain of the skull, you have the actual skull that's protected by several layers of the skull and meninges. It's kind of like way beyond, but I want to show you that the skull is or the brain is well protected by the skull, okay? And injuries can occur at any of these layers. We worry obviously when it gets through to the skull and to the brain the most. And same kind of way that you have primary and secondary for the spinal cord, you can have primary and secondary to the brain tissue. And it's the same kind of idea, right? Your primary injuries are caused by this direct force to the brain and the skull, and then your secondary is going to develop over time. So it might be, let's say, an initial concussive injury that workup's negative, and months later you're still getting calls because they have headaches or they're confused. And that's what we talk about, like more TBIs. Okay, so your scalp and your skull injuries, the scalp can be extremely vascularized, and you guys know this when you go and see there's just blood everywhere. What are some things that you want to do? Obviously, after your ABCs, kind of falling under C is bleeding control, and so pressure dressing, quick clot, all kinds of stuff like that. And actually, in the new ATLS protocol, bleeding control actually comes first, especially for your penetrating blunt traumas. So as long as everything else seems to be quick, intact, like on your ABC assessment can take like literally 10 seconds, not even. And so bleeding control gets kind of bumped up to the top in these serious traumas, which is kind of cool. But what are some physical exam findings that can hint towards a skull fracture? One of the ones that we talk about is blood behind the tympanic membrane. If you guys carry otoscopes, you can always peek in there and see if it looks like that. That's blood behind the TM in that first photo. You got raccoon eyes and battle signs, some bruising behind the ear. We're thinking about the base of the skull fractures. So those are all concerning findings. If you arrive on scene for this guy who got hit by a car on the bicycle, that's quick transport to a hospital with neurosurgery capabilities, right? TBIs. So TBIs range from like a very, very mild injury to a more severe, I'm in a nursing home and I can't do anything for myself type of injury. Knowing the mechanism is key. I kind of threw some like brain bleed stuff in here also. And so knowing how this happened is like, is it the drunk guy who fell 4 days ago and just slowly became more confused and is now obtunded? Or is this, the kid who fell down the stairs playing with his siblings, was fine, and then 30 minutes later was unconscious? So sometimes the mechanism can kind of help predict the injury, and that's the case with traumatic injuries and brain bleeds. Really like this one because I had my Jets in there who won yesterday for the first time all season. Okay, I had to do that. It's been rough for us. Okay, leave us alone. Concussions are mild injuries to the brain caused by a direct injury. This is commonly seen in sports, right? I like this picture because the Patriots player obviously doesn't have a helmet on, and that's kind of the point, is the head is unprotected, have some kind of blunt injury. They may or may not have LOC. Immediate symptoms can be like headaches, nausea, vomiting, sensitivities to light or sound, confusion. And a lot of times especially parents bring their kids in and they're like, hey, I need to make sure he doesn't have a concussion. I'm like, well, he probably does, right? I'm not going to see that on a scan, but I'm worried about, brain bleeds and skull fractures and all kinds of scary stuff. Otherwise, the concussion, unfortunately, is just kind of the least of our worries, but we have very strict concussion protocols. And a lot of times these kids especially bounce back really nicely. But treatment is primarily rest. It's a gradual return to activity. The one that I say that people really don't like is, minimizing screens. So like TVs, computers, cell phones, iPads, like all of that stuff is going to kind of hinder your ability to recover from these concussions. But again, there's really not a whole lot you can do for them. It's just something like, hey, this person had a head injury, and now they have these concerning symptoms, so we're coming in for that. The other one that we talk about is like a contre-coup brain injury. That's actually a French term meaning like the initial blow and then the counter blow. So kind of the same way you think of a whiplash injury in the neck, you think of the same thing within the brain tissue too, right? So you do have a tiny, tiny bit of room in everybody's brain on all sides essentially, right? Because you're cushioned by that spinal fluid. And so when you kind of go forward, you hit the front of your brain on the front of your skull, and then maybe on something else. And then as you go backwards, the back of the brain is also hitting the back of the skull. So that's how we call like when you get hit from the front and then again from the back. That's that counter-coup injury. And basically it's talking about an injury that's remote from the site of the initial blow. Not a whole lot to do about it. We kind of treated this similar as a concussion, but again, cervical spine precautions would be the biggest thing on these patients because you never know what other underlying injuries they may have. This is one you guys probably actually see a lot, is those epidural hematomas. These are the type of like intracranial hemorrhages that I said we talk about a little bit. These are the people that, oh, like the kid fell down the stairs or got hit in the head playing football in the backyard, was fine for 30, 40 minutes, and then all of a sudden they were unconscious and you got called to the scene. For this kid, I'd probably just put him in a cervical collar and be like, well, let's go, we're going to the hospital. But this is bleeding that's between that and from the middle meningeal artery. So it's an arterial bleed, and then typically, like I said, they have that lucid interval, and then all of a sudden they have this just rapid decline. These are the intoxicated alcoholic patients who fall and a couple of days later become altered. These can also be your elderly patients who live alone and don't really see anybody. But this is kind of a slow bleed because it's more of a venous bleed. It builds up over time. And then all of a sudden, like these persistent headaches, nausea, vomiting. And so sometimes, like these people that come in with headaches after what seems like a mundane fall can actually have some serious pathology. Again, as far as what you guys would do, I would still put them in a cervical collar. I would still transport to the hospital because you never know how they fell, right? Like you don't know what else is going on, but just to be like a little bit more cautious about it. Finally, you have your intracerebral hemorrhages, which is, this can be a penetrating or non-penetrating injury. The most common reason that we see this is due to persistent hypertension. So your super hypertensive patients that are just not acting right, this is the first thing I'm thinking about. I've got lots of things on my differential, right? Like we're thinking of drugs, we can try Narcan, we can do all kinds of things. But this is what I'm worried the most about. A lot of these are not survivable injuries, depending on the extent of them. But you want to think about this in a patient who's altered, who's hypertensive, who's maybe like looking one way, like their gaze is to one side or the other. There's not a whole lot you guys can do. I'm not really sure what you carry as far as like antihypertensive medicines, but there's really not a whole lot that you can do because these people usually require cardian in the ICU. But these are kind of really interesting injuries. We had one yesterday that was kind of impressive. It's just really interesting to see the pathology behind all of that. It can also be an aneurysm, all kinds of stuff. And then once we talk about like severe enough injuries in the brain, we talk about herniation of the brain. So the brain is kind of separated by all these, like the false cerebri. You've got a couple different layers in the brain that keep that brain tissue where it's supposed to be. But sometimes the brain swells too much and it starts to herniate. We talk frequently about, going from left to right or right to left herniation. But you can actually also herniate down into the brainstem and into the spinal cord. Again, these are not always survivable injuries, and a lot of them, if they are treatable or neurosurgical emergencies, again, these are just for you guys, like your altered patients. They're not acting right. They're usually hypertensive and bradycardic, right? We talk about Cushing's triad. So there's irregular respirs, bradycardia, and hypertension. Those are some things that are important in your reports, and some things you want to pick up on because they, like I said, can be super fatal. Each of those, depending on which way your brain herniates to, you'll have like cool different physical exam findings, and not exam findings you see all the time. So a lot of times people with concerning stuff will come in before that, but you never know. And so next time we have one, we'll have to kind of stop you guys and show you. But who's at risk of these things? People that are elderly, people that play sports, alcoholics people, homeless people, because they can't really give you a good history as to what happened. Your psych patients, you kind of always have to believe your psych patients have something going on until you prove that they haven't, because they might not even give you the whole story. And then medications that increase this risk, when you guys are asking about like, hey, are you on blood thinners? Are you on aspirin? Those are important questions to ask. And when we get that information, it's super helpful in how we can either stop a bleed or treat an injury, right? It's always the first thing the neurosurgeons ask us too. So it's good information to have for sure. All right, next case, you're on your way to the hospital with a patient who fell at a nursing home. You put a cervical collar on, but as you're on the way there, they become more altered, less responsive. GCS is a 6. What are we thinking about now? Our main concern is like obviously protecting the airway. You guys are extremely limited as far as what else you can do, but protecting the airway is going to be the first thing. And so we talk about what kind of different meds you guys carry and which ones are neuroprotective versus a little bit more harmful. And so how would you intubate this patient? The first thing is you already have them in a cervical collar. You want to leave them in that cervical collar. Makes intubation more difficult, but if you guys carry those little like glide scope cameras, this is the perfect time to use it. Depending on how many bodies you have, I know it's not always a surplus of people, but maintaining cervical spine immobilization is actually done easier if the collar is opened from the front and somebody's kind of holding from the bottom like this way versus like how we traditionally hold C-spine, right? And so that's actually shown to be safer than leaving the collar on and trying to intubate with the collar velcroed in the front. But again, if you don't have the bodies for that, that's okay. Just leave the collar in place if you're concerned about a cervical spine injury. And sometimes you want to do this for your elderly patients with all kinds of weird pathology, right? Like your Down syndrome patients, your rheumatoid arthritis patients, they already have cervical spine instability at baseline, even if they didn't fall. So you want to just kind of be aware of some of that stuff. But multiple ways to maintain cervical spine immobilization. You just want to make sure that you do it. And then as far as some of the meds that you guys carry for intubations, etomidate and ketamine, initially they said don't use ketamine. We think it might increase intracranial pressure. That could be bad for patients, but it actually has been shown, ketamine's like really on the rise right now. And so it's been shown to prove no difference in mortality and may actually be neuroprotective to some extent. For paralysis, you have your rocuronium, you have succinylcholine. Those are definitely acceptable paralytics for brain injuries. And then rocuronium does last a little bit longer in succinylcholine, which can delay a neuro evaluation. But again, safety first, get your airway. It's okay no matter which medicine you give, just give something so you can safely intubate your patient. And then sedation, I don't think you guys carry any of this, but like when you're transporting a patient who's on this, it's like propofol and stuff like that. It can lower their blood pressure. It can reduce their intracranial pressure. So things to think about too. You don't want their pressure to be too low because then they're not getting blood flow to the brain. But that's something you want to go ahead and monitor if you're transporting a patient on propofol. And then you guys probably carry Versed. Versed is obviously appropriate for sedation in these patients, and it doesn't drop their blood pressure as much. And then for analgesia, fentanyl is shown that repeated doses can increase ICP, but 1 or 2 doses of fentanyl is probably not going to be super harmful to a patient. Okay. And then ketamine you can also use for analgesia with addition to propofol and other pain relieving measures. And they don't have significant enough effects on the intracranial pressure. So some things to think about. A lot of the common medicines that you guys give are okay in these like head trauma patients or these like neurosurgical potential patients are okay to use, which is good because it gives you guys lots of options, right? I covered this just a little bit. Like I said, when we're concerned for a C-spine injury, do not extend that neck. Do not try to get yourself into like, the earlobes up with the sternal, the edges of the sternum. Don't do that stuff. You want to keep them in line. And the safest way to do so is to have somebody hold. However, leave that collar on and just go ahead and use your video glide scope if you've got them. The gold standard is going to be the headboard, the collar, the sandbags, the straps, and then the 3 to 4 views on your laryngoscope. But that's okay. Sometimes we don't have that, and we know that. The semi-rigid collars restrict mouth opening. That's the biggest reason as to why they don't want you to leave it on. But again, with minimal resources, you're going to have to. They did also show in a couple studies that the elastic bougies, I don't know if you guys carry those, but the elastic bougies can increase your success at intubation attempts, and you can do it in as little as 35 seconds. So that's super impressive. Out in the field, I know that can be difficult. You guys don't have the resources that we have in the hospital. And so consider using your bougie. Don't be afraid to use that thing. As long as you got a good view, slide it in there, take your glide scope out, drop your tube. Super easy. 35 seconds is an impressive intubation time in the field. So don't forget that. And then obviously your LMAs. If you can't intubate, just stick an LMA in there and get them to the hospital. So if we kind of continue that grandma case, after intubation, we said her blood pressure drops. She's 90/50. What are we doing next, right? If we're concerned for trauma, we're always concerned that hemorrhagic trauma is our cause first, even though she might have been a fall from standing. Like that doesn't mean she's not bleeding into her brain. That doesn't mean she's not bleeding into her belly, right? Like we weren't there. We don't know what happens. But when we're concerned about head or neck injury, we're thinking about neurogenic shock, right? And that is going to be typically an injury that's in the upper half of the thoracic and cervical spines. But like we said, it can be hypotension and bradycardia versus your Cushing's triad, which is bradycardia and hypertension. So all kinds of different injuries you guys got to be thinking about. But the first thing that we're going to be doing when I see this blood pressure, we're starting fluids. And that is never going to be the wrong answer. Okay, because again, hemorrhagic until proven otherwise. And then if you guys carry pressors ever, like if you're running on pressors, just bump those pressures up little by little until you get that blood pressure where you want it to be. Okay, so again, what are some of the final pieces when we're talking about brain and spinal cord trauma? We're talking about managing your ABCs always first. ABC, ABC, ABC. And then when new ATLS protocol reaches you guys, it's going to be XABCDE, which is bleeding control back to airway, especially if the bleeding's significant. But obtain the best history that you can in a brief physical focused exam, right? And then immobilizing C-spine and monitoring mental status on your ride to the hospital, especially when you guys have a long ride. It's 6-7 minutes, a lot can happen, but I'm talking like those 30-40 minutes rides from Nevada or to Nevada or whatever. Keep a good eye on your patient, obviously. Okay, some of these are just some additional cases that I put in here. You had a stuntman on a film scene, was jumping off a first-story building, lands on his feet, and immediately starts complaining of some low back pain. This is an example of a lumbar compression injury. So in addition to his feet killing him, because he probably broke part of his foot, is also you have to worry about his low back. So that force comes all the way up through the heel bone specifically, up through the leg into the low back, and it kind of stops there again because you have a really sturdy lumbar spine. But something you want to think about, somebody who jumped off of something and landed directly on their feet. Okay, patient snow skiing, ran into a tree, knocked himself out. When you get to him, his eyes are open. He is very confused, not answering any questions, couldn't tell you what he was doing, where he is, nothing. And he moves his extremities when localized to pain. When we talk about GCS scores, that's something that you want to think about when you have somebody with head trauma. So you have your eye score, your verbal score, and your movement score. Anybody have an idea of what this GCS might be based on those criteria? I know it's like kind of hard. I always kind of have to look it up. Takes me a minute. I calculated 11 based on that one, but 12 is close. Usually a range is fine. I'm like, I don't know, 11 to 12-ish. But 11 is what I got in this guy. Again, I kind of have to, I'm the kind of girl, I'm like, I got to pull this up so I don't mess this up. All right, case question again. Patient fell in a parking lot, chin hit the curb, so fell forward, complaining of some neck pain. Exam demonstrates motor and sensation weakness in the upper extremities, right? That's that central cord type of injury that we're talking about. So like, can't move my upper arms, my legs feel fine. Just kind of something that you probably see more often than not. Like how many grandmas you see a little cuts on their chin or on their forehead and they landed on the curb. Hopefully most of the time they trip on the curb and they don't have that kind of injury, but you know, we never want grandmas falling. So I'll hang out for just a second for any questions, but there's always just a smidge more. I said that we were going to cover just a little bit of more ATLS stuff. Neuroworsening is a new term that they've actually kind of thrown out there. So when you guys are on those long transports, again, for some kind of injury to Kansas City or Springfield, or let's say like Barnes or something, neuroworsening is a rapid decline in neurologic status. And some of the things that you see, right? And it's interesting that they throw this into terms, right? Because when you're monitoring your patient, these are kind of some of the things that you're doing anyway. These decreases in GCS, like sudden decreases in GCS, new decreases in their pupils becoming reactive. Are they now asymmetric? Are they both dilated and kind of what we describe as blown? New focal motor neurodeficits, like, oh, they were just moving both of their arms and now we can't move the right arm. And then we talked about Cushing's triad a little bit, so I don't need to cover that again. But there's always just a little bit more like new terms that we're kind of throwing out there for our patients. So if you guys have any questions, let me know. Those are my resources. I'll hang out for just a couple minutes in case you guys have anything. Cool. Oh yeah, no worries. Hopefully some of that was helpful. Brain and spinal cord injuries, rough. Oh yeah, great. Great. I don't know if that's still on. I was